So let me go back again to the 5 buckets and give you a little more color. So bucket number 1 has to do with that variation on how providers provide care. And let me give you an example. In my days when I was responsible for running a very large physician network for Partners Healthcare here in Boston, we had a network of 5,600 doctors. It is today one of the largest physician networks in America. And as we looked at it, we realized there was a whole lot of very expensive care that was often unnecessary. And let me give you 2 examples. The first one had to do with MRIs. And oftentimes what we saw is we believed that the utilization of MRI exceeded what was really necessary. So as an example, we pulled the records of 400 people who believed that they needed an MRI due to a headache. And as we looked at the medical records, we learned that in 100% of the 400 cases, the MRI did not change the course of treatment for the patients. Did not. So when we went back to the doctors and we said, why did you recommend the MRI? And the doctor said, well, sometimes the patient had a PPO insurance plan, which basically said that there was no, if you will, dirty word in healthcare, gatekeeper, where there was a physician that said you could or could not have the service. If they had a PPO, they could ask for it. And the doctor said, we don't want to fight with our patients if their insurance company tells them they can have it. We're their advocates, we're not policemen. And that's how the doctors felt, and I don't blame them. Doctors are advocates, that's how they're trained. And the insurance design was causing the patients to insist on making sure they didn't have a brain tumor and they wanted an MRI. And secondly, they said there was a shortage of neurologists and the doctors couldn't get an appointment with a neurologist fast enough to help the patient understand that there were other courses of treatment other than an MRI. And talk about variation in price. If you have an MRI at the MGH, it'll run $2,500. If you have an MRI at Newton Wellesley Hospital, it'll run $1,500. And if you have an MRI at Shields Healthcare, a perfectly fine, excellent freestanding MRI center, not owned by a provider, it'll probably be $700 or $800 or less. And the quality is the same, and the outcomes are the same. And the price is really different. So when we talk about value in healthcare in this day and age, what we talk about is very high quality and very reasonable cost. Value does not equal very high quality and very expensive cost. And in Boston, that's what we have. And across this country, we have great variation with many excellent providers at very high cost, as opposed to very excellent providers with more efficient cost. And it is our job to understand why that variation exists and to do something about it. A second example on the clinical side, on the provider side, also happened to me when I was at Partners Healthcare. We noticed that a physician group in our network had extremely high costs, and we're located in Gloucester. Anybody here live in Gloucester? Because you may recognize this story. And we took the data from those doctors, from that physician group, largely primary care doctors, and we drilled down on the data. And what we found was that the costs for those doctors weren't everything they were doing. It was for surgical costs associated with those referrals from those doctors. And that was peculiar. So we took the data and we drilled down some more. And what we found, it wasn't all surgical costs, it was outpatient surgical costs. So that was peculiar too. And this is the value of data. And we drilled down again. And what did we find? That it wasn't all outpatient surgical costs, it was dermatological costs. And then we solved the puzzle. Because in the city of Gloucester, there was one dermatologist. And his office happened to be in the same building as our doctors. So we decided to look at his claims. And what we found that for every referral that guy was getting from one of our doctors, he was doing an average of 6 biopsies. So my chief medical officer said to me, well, Ellen, I guess he thinks if you don't have any skin, there's no skin cancer. You know, that's what he said. I mean, it was awful. But the story's not over yet. So we quickly disinvited him from being in that building. We threw him out of the building. And we put in telemedicine between the Mass General and these primary care physicians in Gloucester. And guess what? It was much cheaper. The quality was much better, obviously, over the 6 biopsies. And the access was much faster. Because we really looked at the data to figure out what was going on. So we were really happy. We threw out the dermatologist. We put in the telemedicine. Everything was good. Until one day, I'm getting dressed to go to work. And on the news, I'm listening to the news, I hear a story about a physician, a dermatologist in Gloucester who had just been arrested for killing his wife. So I don't know if this was a number of years ago, but I think his last name was Sharp. And he was transgender also, he was. That's exactly right, Nani. So I went, Jesus, that guy was in the same building with our doctors. So it really just gives you a sense of why it's so important not to just take at face value and determine for ourselves why we think there's a problem. But it's really important to have data and to use, as somebody here from CHIA tonight, I met earlier, CHIA, there you are, and you live in a world of data. And data is incredibly important stuff. And for us not to make pronouncements just because we think we know why healthcare is so, but to really think about what's going on in that data is remarkably important. So on the variation story, it's very important. Doctors and other healthcare providers are smart. They all have advanced degrees, and they will respond to data. And it helps to change the variation we see between Minneapolis and Miami, and right here in the city of Boston, between providers by looking at data and understanding it.